So thank you all for joining tonight. We are going to be talking about the nuances of vision for daily living. So going through a nice review of some of the common conditions and kind of what everything is that happens during an eye exam and also how it impacts people in their day-to-day lives. I have no relevant financial disclosures for tonight's talk. So as I mentioned, we're going to talk about the most common causes of vision impairment, particularly in individuals with disabilities, but I'll make some mention of other conditions that can occur. We'll talk about routine eye exams, but also what is done during a functional vision exam. And then we'll talk about the role of functional vision throughout someone's life. So just a quick introduction to who I am. I am a faculty member at New England College of Optometry, and I spend my clinical time examining people with visual impairment in general, as well as people with disabilities who may or may not have vision impairment, but often need that functional vision exam. I go to a number of different sites in the greater Boston area, so hopefully I'll be able to kind of answer questions about some of those things as we go through the talk as well. So let's first kind of talk about the prevalence and understand how many people are impacted and what are the numbers that we're talking about. So in the US, there are about 17% of the population has a diagnosed developmental disability, and about 1.2 percent have intellectual disability. And it's estimated that somewhere between 40 and 75% of people with intellectual disabilities have a vision impairment. In Massachusetts, our numbers are slightly lower than the US population, where we have about 12.5% of people in Massachusetts are diagnosed with intellectual and developmental disabilities, and about 15% have a vision impairment. Okay, so I will click back just for a moment if people want to kind of look at those numbers, though I did read them out loud. And now we'll go forward here to pediatric vision impairment. So there's been a couple of different studies looking at vision impairment in kids. So in the Babies Count study, where they were looking at birth to 3 years, they looked across 19 states, so about 800 children were in that study. And they found that the main causes of pediatric vision impairment were things like cerebral vision impairment, optic nerve hypoplasia, retinopathy of prematurity, and structural abnormalities. In that same study, about 2/3 of the children had other disabilities. And this is trying to look at the National Registry of Children with Blindness or Visual Impairment. And they found that of those other disabilities, 64% or close to 65% were neurological in origin. So things like autism spectrum, cerebral palsy, or seizure disorders. Some had a kind of global syndrome, so maybe a genetic syndrome, chromosomal deficiency, or a major birth defect that did not fall under neurological. There were also some endocrine disorders, deafness or hearing loss, feeding problems, and then about 1/3 had other different conditions. So just kind of looking at, where the impact is, and it's important to understand that even with pediatric vision impairment, 2/3 of the people with pediatric vision impairment had other disabilities. So the vision is often a part of these other conditions, and it's not always well understood or well documented in kids who are experiencing other disabilities. So when we think about what's considered normal, it's important to think about the developmental milestones for children as they're developing their vision. So if you've seen a newborn baby, you kind of think about the fact that their eyes don't really track super well. They kind of look like they're all over the place. But within that first month and over the first 1 to 4 months, they start to become able to focus on and track familiar objects. So maybe that's a toy, or it might be a bright light, or something like that. They can track their parent if they're moving around, things like that. And in those very early days, some of the things that we're looking at when we're thinking about possible vision impairment is for infants who have less sensitivity to bright light, so who aren't kind of blinking and reacting with that bright light or don't seem so bothered. Most infants don't like to be with the bright sun in their eyes. They usually will blink or kind of move their head to get away from that. So if you're not seeing that, that is a possible sign. Absent or delayed blink reflex to a threat. So often pediatricians in those first few months will kind of come towards the infant to see, do they blink appropriately? And delayed or slow development of social smiles and nystagmus, which we'll talk about a bit more, but kind of a rhythmic eye movement of the eyes, not the kind of searching, irregular eye movements that are pretty typical in the earliest days, but a rhythmic kind of repetitive movement of the eyes that doesn't go away. As we get into just a little bit older, over 5 to 8 months of age, we start to see that infants actually have some depth perception. They have facial recognition, and they start to really have color vision. So this is the age where if they're not making eye contact, or it seems like they're not making eye contact similarly to their age-matched peers, that would be concerning. If they're not fixating on familiar objects or faces, so a parent comes close to them and their eyes still kind of drift or wander, they don't follow a toy, or if they have a large eye turn, one eye going all the way in or all the way out that doesn't seem to match the other eye. Again, as they get a little bit older, so 9 months to 2 years, they should start to have some hand-eye coordination. They're grasping objects. They're typically crawling or starting to walk in that age range. So if you see kind of a lack of awareness of their own hands or an absence of goal-directed hand and arm movements, that could be a sign of vision impairment. So they're not really reaching towards something familiar. They may just kind of move their arms more randomly. Once we get past age 2, it can be a little bit easier to start to pick up some of the signs of vision impairment. Typically, kids over age 2 are crawling, walking, exploring the environment. And, some kids are just clumsy, but if there are children who seem extra clumsy with their crawling, they're having a hard time reaching toys, they're holding objects really close to their face, again, kind of more than a typical child. Many kids hold it close to their face to kind of investigate it, but if it seems like they're holding it extra close, and if they have trouble navigating curbs or steps or small inclines at playgrounds, those are all signs that something more could be going on. And then school age, it's a little easier to tell. So we expect kids to start being able to read, to identify letters and numbers. And if they're having trouble doing that, we would be concerned, as well as if children are complaining of headaches. So it's a less common complaint in young children. Even when they're experiencing it, they don't always know to report it. And they very rarely know to report blurry vision to you because they don't really know what clear vision looks like if it's been blurry their entire life. So when we're talking about what could be happening in individuals with disabilities, we typically divide things into 2 different categories. We talk about things that are ocular in nature, so something going on with the eye itself, and things that are brain-based. And we'll go through these in a bit more detail, but ocular causes things like refractive error, which is just the need for glasses, can be significant, can require kind of a little bit of complex management, but that's typically meaning the need for glasses. It could be from strabismus, so like I mentioned, an eye turn. There could be binocular vision concerns or oculomotor dysfunction. And so these are things like difficulty focusing up close, difficulty coordinating the eye movements, especially for tasks like reading or anything that requires kind of a consistent, stable movement. And there could be eye diseases or pathology like keratoconus, which is a change at the front of the eye that we'll talk about more, small optic nerves or optic nerve hypoplasia, retinopathy of prematurity, and charge syndrome are some of the most common. And then when we talk about brain-based vision impairment, we're talking about cerebral vision impairment specifically. And we're going to spend a lot more time talking about that, so I'm not going to go through much detail right now. So going through each of those conditions in a little bit more detail, as I mentioned, refractive error is just needing glasses. And I say just because it could be something pretty minor. But when we're thinking about individuals with disabilities, they may not always be able to participate in certain aspects of the exam as what might happen during routine eye care. The terms that you'll see used for things like refractive error are things like myopia, hyperopia, astigmatism, and even presbyopia. And early identification of refractive error is important so that people don't develop what's called amblyopia or a lazy eye. So when there are large prescriptions or unequal prescriptions between the two eyes, then the retina is not getting a clear image, and then the brain is not getting a clear image from the retina. That underdevelopment is called amblyopia, and if it's not corrected in a reasonable time frame, typically by age 8 or 9, then the person will very rarely develop normal vision later in life. There's some exceptions. We have seen some improvement much, into people's teenage years or even beyond. But early identification is really important, getting people into glasses if they're needed, and then occasionally even patching the good eye to encourage that weaker eye to develop appropriately and to get that nice clear image. It's estimated that about 60% of people with disabilities have some sort of refractive error. And once we get past the age of 45, it's basically 100% because everybody develops what's called presbyopia as they get older, which means it's a limited ability to focus at near. For many people, their world is a lot of near engagement and near tasks, especially if they're using an AAC or they're using an iPad or they're doing other things up close. So we want to make sure that as people get into their 40s, that we're assessing whether or not they need reading glasses, even if they never needed glasses before. When we're determining refractive error, what we're looking at is a lot of different components. We're looking at the length of the eye, the power of the lens inside the eye, the curve of the cornea, the clear part at the front of the eye, and how all of these things interact. In some cases, people can participate in that subjective process of determining if they need glasses. So we ask them, which is better, one or two. And in other cases, we have to rely on more objective testing techniques to figure out what prescription is going to be appropriate for the person. So some of the things that you may think about when you're working with someone and you're wondering, could they possibly have refractive error? Squinting and eye rubbing are big ones. Usually that means they're not seeing super clearly. Getting really close to something, or in the case of presbyopia, pushing something further away or backing away from near material because they can't focus so close. A family history of early eyeglass wear. So if parents say, well, I started wearing glasses at age 7, we're going to be thinking about it around that same age or a little earlier. And then in certain conditions that are even more highly associated with high prescriptions, like in cerebral palsy and Down syndrome, as well as some others. But definitely want to be kind of watching those behaviors, engaging that eye rubbing, the brow rubbing, the squinting are definite signs that something could be going on visually that could be corrected with glasses. And so, if we leave refractive error uncorrected, I think it's probably obvious to everyone here, but that can really impact learning. It may impact depth perception, And it can impact overall functional development because if you're not getting clear input through your eyes, that can impact how your proprioception is developing, how you're interacting with the world around you, orientation to space, and communication, as well as the amblyopia I mentioned. And in terms of communication, it's both seeing other people and seeing their facial expressions well and understanding that and learning to communicate that back, and also looking at AACs and other communication devices. So when we're trying to address refractive error and amblyopia, it can sometimes be super easy. We can prescribe glasses, and it is not always so easy. In some cases, if it's a really high prescription, we're going to be thinking about contact lenses if the person is comfortable with that strategy. Contact lenses help address the thickness of glasses, the weight of glasses, and often they can give better vision when people have really high prescriptions. If someone is developing amblyopia, we may even put in a contact lens that's super blurry into the good eye so that they're kind of forced to use the weaker eye. This is nice for people who can't tolerate an eye patch, because if you can get that lens in first thing in the morning, you can keep it in for a few hours rather than a patch that someone might be taking off a lot if they have a lot of sensitivities around their face. We can also use eye drops to blur the better seeing eye to try to get that weaker eye seeing better. And sometimes we have to just do some desensitization to help people become more comfortable with whatever strategy it is that we're going to be using. And so in the desensitization, what we're trying to do is increase the person's comfort with whatever it is that we're going to be using. In some cases, this would be for glasses wear. It may be for accepting eye drops, whether that's daily for amblyopia or whether that's just so we can get a thorough eye health assessment. And sometimes it's just allowing the eyes or lids to be touched, again, for kind of a most comprehensive exam. I have worked with patients who have taken 6 months to a year to really be comfortable wearing glasses, often starting even just 2 and 3 minutes at a time. So we work with the patient and their family or their caregivers to figure out a good approach to helping them become more comfortable with the treatment strategy and increase their sensory tolerance as time goes on. So we'll move on to the next condition, which is strabismus. So this is sometimes called a lazy eye as well. It's truly meaning an eye turn, so an eye that is not focused in the same plane as the other eye. Really variable prevalence in the literature, 26.5 to 44.1%. Again, signs like squinting will happen. That's pretty common in strabismus. Closing or covering an eye. I've even seen people with bangs pull their bangs in front of one of their eyes to kind of block out that image. And actually seeing the eye drift is a big sign. We often see the biggest drift when the patient themselves is very tired or is ill or just after an illness. It'll be much more noticeable. People might complain about depth perception issues, but they might not, because it might be the way they've always known things. You may notice that they don't have as good of depth perception as others. If it's a newer onset or it's intermittent, so it's not happening all the time, they may complain about double vision, and they may complain about eye fatigue. And there's just some pictures over on the right showing that top picture, esotropia, so that right eye is kind of pointed in, whereas the left eye is pointed straight. In the middle picture, it's exotropia, so the left eye is still pointed straight, the right eye is drifting out. And in that bottom picture, it's a hypertropia, that right eye is up compared to the left. It's not always so obvious, and esotropia, that top picture, tends to be the hardest to see, especially when it's small. rather than kind of larger, more significant. We see strabismus in a variety of conditions, cerebral palsy and Down syndrome, definitely high prevalence, should also be considered in autism, in Prader-Willi syndrome, and in a variety of other conditions. For strabismus, there's a lot of different treatment options, sometimes starting with just glasses, may also involve patching or vision therapy, and it may involve surgery depending on the size and angle of that eye turn. So I briefly mentioned binocular vision concerns and that strabismus can play a role there in making things a little bit more difficult for somebody. And when we're talking about binocular vision concerns, what we're talking about is having issues focusing with both eyes, and it can happen even without strabismus or a true eye turn. When we try to look and focus on something, we need both our accommodation, so our ability to shift the lens of our eye forwards to focus, and our vergence. So when we look close, our lens shifts forward and our eyes turn in somewhat to focus. And then we also have the oculomotor system, which is for things like tracking an object, reading a page, following a moving target. That all comes into the oculomotor dysfunction area. There's not a lot of data on prevalence, but generally it is thought that people with some disabilities have more binocular vision concerns than people who do not have those delays. And oculomotor dysfunction is one of the most common that we see. Some of the signs and symptoms that people may talk about are difficulty keeping one's place when reading or using a finger to guide them when reading, difficulty tracking and shifting focus from distance to near or vice versa. So this often comes up in the early school years if students are struggling copying from the board or they have very poor penmanship. And it seems like they should be doing better than that. They don't have a specific like OT concern with their hands, but they're having trouble with that copying task or writing. They may complain about blurry or double vision, and they may complain about eye strain and fatigue with near tasks. But even if they're not telling you they have those symptoms, watching how they're trying to read or look at images and how they're tracking and shifting focus can be insightful. I always recommend that people who are diagnosed with ADHD also have a binocular workup. There's a lot of overlap in symptoms, and we want to make sure that we're not diagnosing one and ignoring the other. People can definitely have both. So we want to just kind of optimize their visual system if they are diagnosed with any kind of attention problems. Should also be considered in autism, cerebral palsy, Down syndrome, and anyone with a history of traumatic brain injury. So I mentioned nystagmus briefly as something to be concerned about. Sorry, I know this video can be a little bit hard to watch, but it is regular, involuntary, rhythmic eye movements. This video is a bit faster than kind of your typical nystagmus, but it is a kind of nystagmus. It can occur in many different types of congenital eye diseases like albinism. It can also develop as people get a little bit older. It can also be considered in Down syndrome and cerebral palsy, although a little bit less common there. And typically the eye movements themselves are pretty noticeable. And so the pediatrician may pick up on it, the parent may pick up on it and be aware. Many people with nystagmus have adjusted head postures to try to find the spot where it's the least bothersome and where they have the best vision. And then excuse me, the nystagmus typically becomes worse with fatigue or illness. If the nystagmus starts later in life, then people will comment that they feel like the world is moving. They don't feel so balanced. Things seem like they're swaying. But if you're born with nystagmus or develop it within the first year or so of life, people don't typically describe that because their brain is very well adapted to it. And we'll get off that video. So as we kind of look through the different structures of the eye. So we've talked about the refractive error and the positioning of the eye, but there can actually be conditions all throughout the different structures of the eye that may impact people with disabilities or otherwise that they may or may not always be able to communicate. So we've found that in the literature, 35% of people with disabilities will have some kind of finding in the front part of their eye. About 18% of that is the eyelids, and about 17% of that is lens opacities like cataracts. So when we talk about eyelids, we're talking about blepharitis, which is an inflammation around the eyelids. It causes some redness, some crusting, some discharge. People may have congenital ptosis, so they're born with one or both eyelids drooping down a little bit. And as we also said, they may have congenital cataract or lens opacities that are impacting their vision. If somebody has blepharitis, then they often also have dry eye. And what's hard about dry eye is that most of the time you end up with more tearing. And so people don't realize that that means that their eyes are dry. So with these front of the eye conditions, blurry vision is a common one. You may actually see a cloudy appearance. So in this picture here, this person has a cataract in the very center. And it looks kind of cloudy, whereas if someone didn't have a cataract, this center area would just be all black. It wouldn't have that white spot in the center. People get that excessive tearing, discharge, potentially light sensitivity, variable vision, or an increased blink rate. You might see them blinking a lot. And they may have worse function in low lighting or in highly glaring environments. So especially with cataracts, if someone is facing a window and they're very uncomfortable, or if they're in a grocery store or school gym with a lot of overhead lighting and reflective floor surfaces, if they become a lot more uncomfortable visually there, we're thinking about what may be going on at the front of the eye that would be impacting their function. These front of the eye conditions are more common in autism and Down syndrome, and in anyone who has kind of frequent eye rubbing or eye poking or behaviors or other kind of stimulating behaviors with their eyes. So when we're trying to treat these conditions, we're often trying to treat them even if people don't have symptoms, if we are seeing that there are signs. So we want to make sure the eyes are comfortable. We want to treat any dryness or allergies. We want to reduce eye rubbing behaviors if we can. So if we can get the eyes more comfortable, that sometimes helps with eye rubbing. Really good lid hygiene, so gentle lid scrubs first thing in the morning and later in the day. Frequent hand washing, especially for people who are touching their eyes a lot. Keeping the nails trimmed. A lot of bacteria can get stuck under your fingernails. And looking at medication prescriptions if there are really significant findings that are impacting someone. If it's a cataract that's impacting the vision, then we would be looking at cataract surgery. So when you have a lot of eye rubbing, one of the other things that can happen is a disease called keratoconus. This is not just associated with eye rubbing. There are also some hereditary components, highly associated with Down syndrome. And what happens is that the cornea, the clear part at the front of the eye, develops significant astigmatism. And so that front surface becomes so steep and irregular that the vision cannot be corrected with glasses. So many people with keratoconus have this blurred vision that's no longer correctable. They have increased glare sensitivity, and they may even develop pain at the front of the eye. I'm not sure if you can appreciate it or not, but in the bottom picture, it's showing that that front of the eye is a lot steeper. It doesn't look kind of nice and round. It looks more kind of like a cone, which is from that name, keratoconus. There is a very minor surgical procedure called corneal cross-linking that can slow the progression of keratoconus. And there are also a lot of specialized contact lenses that can be prescribed to help improve the vision, even if it can't be improved with glasses. The biggest key here is prevention as well, so reducing eye rubbing whenever possible. Moving back a little bit further into the eye, we're going to talk about some of the optic nerve conditions. So one of the more common that we see, as I mentioned on a previous slide, is optic nerve hypoplasia, which means small optic nerves. And we also see septo-optic dysplasia. So optic nerve hypoplasia can occur on its own. The incidence there is about 1 in 10,000, but it can also occur with septo-optic dysplasia and cerebral palsy. In some cases, optic nerve hypoplasia, like I said, in isolation, it's totally on its own. No brain abnormalities, nothing else going on. But if it is associated with septo-optic dysplasia, then we do see a variety of different brain abnormalities, especially in the hypothalamus and pituitary. For people with optic nerve hypoplasia, in some cases, they can have basically normal vision, just a small optic nerve for whatever reason. And in some cases, they can have profound to total vision loss. So sometimes even no light perception vision. And it's hard to predict what someone is going to have when you look at the optic nerve. You can't pick out a nerve and say, well, that one is this amount smaller than normal, and therefore that person's going to have no vision. And this one is this amount smaller, and they should be pretty normal visually. We don't have a way to predict that, so we just have to do the testing to find out. So, in terms of eye diseases at the back of the eye, so this is including the retina and the optic nerve, individuals with disabilities, they found about 13.8% have findings at the back of the eye. Some of these are not super visually significant, things like a tilted disc or myelinated nerve fiber. Those are not usually visually significant in any way. Small percent have optic atrophy, some tortuous blood vessels, things that we would monitor closely. And about 1% of individuals with disabilities have glaucoma. It is higher in Down syndrome. And in a small study in Taiwan, they found that there was a higher percentage of people who were at risk for glaucoma when they were looking at high school students. And we typically think about glaucoma as a disease that doesn't start affecting people until their 40s or older. So it is unusual to see that percentage of high school students being flagged as suspicious for glaucoma. People with disabilities are more likely to develop diabetes, and it's thought that about 16% of adults with disabilities have diabetes compared with only 7% of their counterparts. So it's a pretty significant amount. Again, necessitating comprehensive eye exams to make sure that they are being managed appropriately and that we are intervening if treatment is needed. Also in the back of the eye is a disease called retinitis pigmentosa. This is a progressive photoreceptor degeneration, which leads to peripheral visual field loss, vessel tortuosity, and increased risk of early cataracts. Retinitis pigmentosa has many, many different genes which can cause it. The reason I'm including it here is that there's a couple of syndromes that are associated. One is the Bardet-Biedl syndrome, and 50% of individuals with Bardet-Biedl have an intellectual or developmental disability, and they almost all develop retinitis pigmentosa. And there is also a kind of separate category of intellectual developmental disorder with retinitis pigmentosa that's just considered its own entity, and it can co-occur with ADHD. In retinitis pigmentosa, that peripheral visual field loss is often fairly gradual, but it can ultimately lead to total blindness, and it can really impact a person's mobility and independence. Often people complain about night vision problems or difficulty seeing in the dark before they complain about issues during the day. Though not everyone presents that way, but most people have more difficulty at night first and then later during the day. So when we're talking about what people might say if they have one of these eye diseases impacting the back of the eye, they might complain about flashes and floaters. So sometimes flashes and floaters are just happening and don't mean there's a disease, but they almost always warrant an exam to make sure. Blurred vision, loss of color vision or feeling like colors look more faded, or if you're working with them and you're noticing they're not identifying colors very well, that could be a sign of an optic nerve or macula problem, especially if they used to identify colors well and now they don't. Night blindness and loss of peripheral vision, as I mentioned, especially with retinitis pigmentosa. And when we're talking about these back of the eye diseases, in terms of the impact on daily living, we do see more social isolation when people are experiencing eye diseases, especially those that impact peripheral vision, because that impacts mobility so much. So people will not be as comfortable in dim or dark conditions, or they may be less comfortable going to crowded environments or unfamiliar environments. And if they have problems in their central vision, they may start to have more trouble with facial recognition and more difficulty seeing television or going to plays or shows or things that are more distant tasks where they need detail. And so many people will stop engaging in those activities, even though they don't necessarily identify that as the reason why. We also see that worsening mobility, as I've mentioned, as well as more glare concerns. So now that we kind of covered a lot of the conditions that are impacting the eye itself, let's talk a little bit about the brain-based vision impairment or cerebral vision impairment. So for those of you who are not super familiar, cerebral vision impairment is a neurological vision impairment related to visual perception and processing. And it's most often related to early brain injury. So in the prenatal or perinatal periods, though it can develop later in life if there is an injury or another disease that develops. So again, there can be some overlap with autism. So this is something we would want to at least rule out if we're concerned about how an individual with autism is functioning visually. Very high consideration in cerebral palsy, in Down syndrome, in epilepsy and other seizure disorders, in fetal alcohol syndrome or neonatal abstinence syndrome, anyone with premature birth, especially extended NICU stays with significant oxygen support, hypoxic ischemic encephalopathy, and a variety of genetic syndromes. So kind of any complex birth history is going to raise a flag for the possibility of there being a cerebral vision impairment, knowing that we would need to do a full workup because you can have many of these things and still develop normally visually, but that is not always the case, and we want to make sure we support people if they are experiencing those symptoms. So when we're looking at CVI, we're thinking about where it impacts people. CVI can impact how people function in terms of complexity, in terms of motion processing, visual attention, variable visual fields, and kind of generally variable use of vision. So sometimes maybe really visually engaged and other times completely disengaged, and in visually guided movement. When we think about this in daily life, it's when people are not looking at objects that they're working with. So they're kind of, their hands are engaged in a task, but their eyes are somewhere completely different. We often see that people actually have to actively disengage to reach for something. So they'll, look to the left and then reach their hand to the right to pick something up. That's a very classic behavior in CVI. We see difficulty in crowded and complex environments or new environments. In a classroom setting, it may be that a student becomes overwhelmed when the desks are in a new orientation or things have been arranged differently. And sometimes difficulty finding objects that seem fairly obvious, or even running into or tripping over things that seem pretty visible to someone who does not have CVI. And so, when we're trying to figure all of this out, how do we examine people? What are we doing in that eye exam when you're maybe thinking about an exam you've had, and how does that apply? How do we make that work if someone can't always communicate back to us in the same way as another patient? It in many ways, it's exactly the same as how we examine anyone else, though obviously some modifications. So our goals are to get the clinical data that we need, to assess the ocular health, and to get the functional data and information. So we want to know, what does this person see? How much detail can they see? What are the smallest letters they can read, or the equivalent test if they're not able to read letters? We want to know how the peripheral vision is. What are their visual fields like? We want to make sure we've assessed for glasses or refractive error. And we want to know contrast sensitivity. So how does someone do when things are not purely black and white, when there's shades of gray or colors? Are they still able to see that as well as they are when it's nice and bold? We want to assess the eye health. So we'll look at the pupils, at the eye muscles and how the eye muscles work together, at the eye pressure. And if they're not having dilated exams elsewhere, we will dilate our patients to get that full assessment of the back of the eye. Once we have that information, then we start looking at some of the functional data. And so we want to know how somebody is using their vision for working, for navigating, for learning. Sometimes this involves a lot more questions. Sometimes it's observation of how that person is interacting with the world. We do some different puzzles and games to kind of see how somebody approaches those visually guided tasks and compare how they're responding to the normative database of how other people without CVI would react and how people with CVI more typically do that. And then we look at functional fields, how, even if somebody can do certain peripheral vision tests, if they're really engaged in another task, are they still aware of their peripheral vision? So, it's really important that we review any and all medical conditions that someone may be diagnosed with. Past eye exams or other medical records, when they're available, can help us understand how to make sure that the exam is going to best engage the person and make sure that we know what information we're collecting. If we're working with students, we like to review the IEP if it's available, if it's already established. That can help us address specific concerns that the team members have. And we will also use some of the kind of online resources like rarediseases.org to identify specific findings that we would want to address with a rare disease, where we may not always know all of the ocular findings that might go with a particular genetic syndrome. There's some really great resources so that we can be certain we're providing that comprehensive care. Once we finish going through the history, and, I would say that we jump around a lot when we're especially working with young kids. We want to move around and kind of engage them where we can engage them and shift to other activities if we need to. Social stories can be super helpful. So pictures of the actual space. This is a colleague with her daughter. They made a social story to kind of help her with the process of going for an eye exam. When I am seeing patients at one of my locations, often the teachers or the teacher of the visually impaired will prep the students with a social story and visit the space. We try to allow extra time to acclimatize to the room, and super important for me to know what people's favorite music, videos, toys are so that we can have on familiar things and uh, make sure that someone is comfortable. So sometimes that is Taylor Swift, sometimes that's Pete the Cat, sometimes that's Paw Patrol, kind of whatever people are interested in. We will pull up a YouTube video, we'll play the music, we'll try to make it as comfortable and fun an experience as possible. As I mentioned, when we're performing the exam, observation is super critical. So how did they navigate the space? Are they walking? Are they using a mobility aid? Are they relying on someone to guide them? Are they independently mobile? How's their posture? Do they have a notable head tilt or head turn? And, are they cutting it close at a corner, or are they kind of moving into the room without too much trouble, especially in tight spaces? We can even monitor kind of differences in floor patterns. Do they pause? Are they slower when they're going from carpet to tile or vice versa? If we're able to observe that in our location, we will. We want to look at the type of communication. Is this someone who's communicating verbally? Are they communicating non-verbally? I really try to narrate the steps of the exam as I'm going and make sure they're comfortable, even demonstrate on one of my students or have them demonstrate on me before we do a particular test, just to make sure that they're really aware of what's happening. When we're measuring vision, there are lots and lots of different ways we can do it. So if somebody is not able to tell us numbers or letters or shapes or anything like that, we can do matching. So we'll sometimes show these picture shapes at a distance and then have them match. We have a brightly colored puzzle that they can pick up the piece and put it in. But if they're not able to do that, we can also do what's called preferential looking. So that's the top picture where you can see those black and white stripes. This works even in really young infants. So typically you're going to look towards the more interesting things. So you're automatically going to look towards the stripes instead of the gray side of the card. Sometimes I've had a couple of people who are a little bit older, a little more sophisticated, play tricks on me, and they will consistently look away from the stripes just to see if I'm paying attention. But usually we can do this. It's kind of a reflex. You watch really closely from behind the card. I'm not sure if you can appreciate, but there's actually a very small hole right in the center. So the person holding the card can peek through that hole to watch how the items move without knowing which side the stripes are on. So you don't have a biased observer. They can watch and make that objective determination of where the person looked. The nice thing with these various tests is that we can do this in free space. So we can do it outside of the exam room. So that might be a couch or a beanbag chair, or even if I'm in a school, it might be in the student's classroom where they're more comfortable. Typically, I'm going to start by measuring both eyes first and then towards each eye. We really want to know what the vision is in each eye, but that's not always possible. And both eyes gives a good functional measure before we fatigue someone. But if there are some tactile sensitivities, we will work on different ways to cover an eye. You can see in this picture, they're using a sticky note on the glasses, so sticky patches, sticky notes, a tissue behind the glasses, things that are kind of easier, make someone more comfortable. And we usually do the vision testing in full lighting, though if we need to, we'll do it in dim lighting to better direct attention to the chart. I mentioned that we need to do some tests of contrast sensitivity. We like this measure if possible because it is thought to be a very real world measure of vision, and it helps with object detection and changing thresholds. And it can let us know if the reason someone is tripping or having trouble with their mobility is if it's a contrast issue versus a visual processing issue. That can be helpful for us. Most eye exams really only use high contrast materials, but the real world, as you can see in that top picture, has all different kinds of contrast levels Those stairs don't look so bad if you have normal vision, but if you have reduced contrast, it almost looks like a slide or a ramp. Contrast really varies in variable lighting and glare conditions, and it's really critical for facial identification. And I put a picture of one of the kids' books that I have in my house, and you can see that difference in contrast there between the Have You Seen My is nice and black and bold, and then Invisible Dinosaur, it's still outlined, but it's definitely less visible than the black print. Some different ways we can measure contrast, so we can have people read letters as they fade. We can also have people look towards the happy face. Same principle as the stripes. People are more likely to look towards the more engaging image. And so eventually the cards will look just totally white and they'll kind of look randomly. But when they are able to see it, they typically will look towards that more engaging image. When we're looking at visual fields, we're going to try to get a measurement. Usually we'll have the person engage in a target far away. We don't want it to be so engaging that they ignore us completely, but engaging enough that they're a little bit distracted. And then we will bring a light in from behind them and kind of shine it until they kind of turn their head and look towards the light. We also ask history questions, so asking about bumps, trips, stumbles. Do they seem to be clumsier than their classmates or friends? If they're using an AAC or a computer screen, are they using the full screen or do they seem to ignore parts of it? And how do they do in gym classes and crowded environments where there's unfamiliar things going on? And how's the visual search? Can they locate an object when it may have dropped or fallen, or if they're looking for like a favorite toy, or if they're looking for food in a cabinet, can they do that visual search fairly easily? So the testing is often done with both eyes open, again, for the best functional assessment. If I'm examining an adult in a typical clinic exam, then I would do each eye individually. But when I'm doing a functional assessment, I'm doing both eyes open. We may do a static target, so a target that's not moving, or we may do something kinetic, so it's moving. And you can see in those pictures kind of what I was describing. So in this case, the person's looking at the examiner and they're bringing a light around from the sides and from behind. I often do this with two people if it's possible because it just makes it a little bit easier. And we want to help maintain attention where possible. We use a lot of different puzzles and games. So this puzzle on the left has this colorful side, and then the other side is black and white. So you can see if somebody engages with the puzzle differently, whether it's black and white versus whether it's colored. These puzzles over on the right have varying degrees of complexity. We will often show it to a student not assembled and kind of see how they do. And then we'll show it to them assembled, then take it apart and see if having that kind of visual memory changes how they engage with the puzzle. Again, kind of watching the behaviors, and are they doing it more tactily? Are they doing it more visually? Is it some combination, and how they're able to kind of put those shapes together? We look at how somebody processes complexity. And so there's a series of cards where we ask someone to find the yellow duck. In that first picture, on the left, it's the easiest. And as we work through the other pictures, it becomes more complicated. There are more distractors. So, does someone kind of look to the sponge first? Do they go back and forth? They've got the extra distractor here of the shower curtain being yellow. The tap is now yellow. And then going into the most complex, there's a lot going on. The duck has moved. There's yellow towels. There's a yellow boat. There's the yellow sponge again. So how does someone process this? Do they have a systematic way that they're looking at the picture? We watch the eye movements and kind of see, are they able to handle the complexity and find that duck in these various series of cards? In terms of assessing binocular vision, when somebody is not necessarily able to communicate back to us, we will try to engage someone with a favorite toy, a phone with a video that somebody really likes, flickering toys as long as it's not a seizure trigger, anything to kind of engage someone to get them looking and following. We will test depth perception with, there's a number of different tests. The one on the bottom I really like because it's looking for a happy face. It's fairly motivating. Generally, people can do that pretty easily and they can just point or look towards the happy face. For color vision, sometimes we're doing really simple tests. We'll ask people just to put the black circle on the circle on each card. That gives us a sense of kind of general color vision. If they're not able to do that, we may do things like color matching. So can they match that this blue fishtail goes with the blue fish? So not quite as discriminating as the formal color vision test, but helpful to see, can they discriminate, blue from purple that might look really similar? Or even here on the caterpillar, we can have them match up the colors. So can they put all the greens together? Can they do that task visually and distinguish those colors? So some different ways to at least have a sense of how discriminating someone can be, even if they can't necessarily name the colors in a particular way. And then for the eye health evaluation, we try to do as much as we can in free space with handheld equipment. We try to keep things super portable, keep people out of the exam chair if that is an intimidating situation, and trying to kind of help position people, especially if they're in a wheelchair or if they're not super comfortable kind of positioning upright in the regular microscope. We'll do that free space evaluation, and we'll spend a lot of time prepping people to become comfortable with the idea of the eye drops. And so, we're going to do all of that testing and all of that history collection and all of kind of the details about who the person is, how they're using the vision, with the goal of remembering that all of the information we're gaining is to try to help people use their vision the best possible in all of the different aspects of daily life. And so we're going to come up with a plan that will help people in school or work or home, looking at mobility and for activities of daily living and figuring out as much as we can from our exam. It might be one or two or might be a few exams to really understand how that person is using their vision and what they need to optimize their function. When people are dealing with vision impairment with or without other disabilities, we really want to also check in on how people are coping and managing with the vision impairment. Are there mental health concerns? Are people starting to feel socially isolated or more depressed if they are having changes in their vision? And what kind of support system do people have? We do our best to keep the visits very patient-centered. What is that person's goal, or what are their care team's goal? And also making sure we can acquire the information we need to. As I said, for some people, that might be multiple visits to really get a complete picture of who they are and how they use their vision. And we want to try to maximize what we can accomplish in one visit, but also be cognizant of the fact that we might be fatiguing someone and that they might need a bit of time to get comfortable with our clinical setting. And so we may split things into multiple visits. So I'm going to wrap up there with hopefully plenty of time for questions.
So good, yeah. So the first question coming in is, what accommodations would you recommend for a middle school student with nystagmus?
That's a great question. So, it depends on the vision. So people with nystagmus can definitely have a range of vision. I would say one of the big things we look at is the null point. So that's the head position or eye position where the nystagmus is minimized. And we usually communicate to the school that, it's most optimal if they sit on the left of the room or the right of the room or something like that, so that they can be most comfortable in terms of their head and neck posture. With nystagmus, we're also often looking at larger print, potentially the use of apps or telescopes or other devices, but it really depends on the level of vision. Sometimes it's even incorporating audio, depending on the level of vision. But definitely kind of awareness of the null point, awareness of kind of how they're using their vision, and educating the team members that the eye movements are involuntary.
Perfect. Yeah. All right. So can you explain the tiny hole slide again?
Yeah, so basically there's a series of cards. They're all um, pretty large. One side is gray and one side has those black and white stripes. In the beginning of the test, the stripes are really bold, like you saw in the picture, and pretty well spaced. And then they get closer and closer together, kind of finer gradings, as we're measuring better vision. And so the examiner is behind the card looking at the patient, and the examiner doesn't know what's on the front of the card. So they're just looking, and they're looking at which way the patient moves their eyes. Do they move them to the right or to the left? Once they've judged where the patient moves their eyes, then they will look at the card and see, did the patient get that correct? Uh, and so we go to finer and finer gradings where it becomes harder to distinguish whether it's gray or whether it's a grading. But people will typically always look to the more interesting place, so towards the gradings as opposed to just the blank side of the card. And so it's an objective way to see how much resolution does that person's eye have. Typically overestimates a little bit how someone's going to function, because it's just kind of which way do they look and not how do they actually process that information. But it does give us a decent sense of kind of what they can resolve when they're looking at gradings. Hopefully that made sense.
Okay. Yeah. It looks like that does take care of all the questions that are coming in. So thank you again so much for presenting tonight, and thank you everybody for joining us. Oh, we got one more question. Let's see. What do you recommend for activities or accommodations for an 11-year-old with CPI who does not process motion?
Um, so, typically we're going to have the teacher of the visually impaired kind of working on different activities. So, starting with really salient targets, so things the person is super engaged in, and seeing if they can start to track and follow those really engaging things. Um, I am not a TVI, so I don't want to go into too much detail about what a TVI would specifically work on, but that's one of the things I recommend, is really identifying what types of targets are visually engaging and using those to try to get the person to then engage with the motion and process it, uh, and trying to present kind of key curricular materials in a non-moving way. So we don't want key materials needed for learning to be presented in a way that can't be processed, but making sure that engaging and interesting objects are used to kind of stimulate that awareness and processing in either the training sessions or the sessions with the teacher of the visually impaired, where they're working on improving that skill of starting to process motion, if that makes sense. So
Yeah, and I think she's expanding on the question a little bit, asking basically about cars and related to not being able to cross the street safely.
yeah, so I think that is where I would add in an orientation and mobility assessment, and seeing if other senses can even be used. So even though the person may have vision, I'm kind of assessing them as if they don't. So someone who's totally blind would use other cues to cross the street, so they would use more auditory information. And so, perhaps teaching that person to go through some auditory training and depends on their cognitive ability. Can they turn off their visual system in some way to rely on the auditory for things like street crossings? So instead of trying to gauge the cars, really learn to do it auditorily if they have good auditory processing. I think that is often a strategy we'll use for safety when they can't process the information visually. And that would be done in conjunction with a mobility instructor. Sometimes they even do some of those tasks blindfolded, although most of the time not. Most of the time they try to kind of work with someone, but teaching them to use those other systems and senses.